Welcome, everyone. Thank you for joining us today. My name is Kerry Grady Vincent, and I'm the Senior Manager of Clinical and Educational Programs at Osteoporosis Canada. I will be your moderator for today's healthcare webinar entitled Osteoporosis Management, the Importance of Fracture Risk Assessment and Treatment. The webinar today is supported by an unrestricted educational grant from APOTEX. Before we begin, Osteoporosis Canada acknowledges the land that our offices, located in Toronto, are on is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples, and it now is home to many diverse First Nations, Inuit, and Métis. We also acknowledge that Toronto is covered by Treaty 13 with the Mississaugas of the Credit. Osteoporosis Canada is the only national organization serving people affected by osteoporosis, working to educate, empower, and support individuals and communities on bone and muscle health and in the risk reduction and treatment of osteoporosis. Our Scientific Advisory Council is made up of experts from across the country in osteoporosis and bone metabolism and is a volunteer membership. Comprised of clinicians, researchers, and educators, the SAC advises our board and staff on scientific and medical issues. OC provides medically accurate information to patients, healthcare providers, and the public. Our services include programs and support groups, educational webinars, podcasts, digital tools, and resources available at osteoporosis.ca. We are really excited about today's presentation, which will provide information about osteoporosis management and the importance of fracture risk assessment and treatment. This webinar focuses on the importance of recognizing the burden of disease, prevalence, fracture outcomes, and the treatment of osteoporosis and fragility fractures. It will address the importance of prioritizing osteoporosis screening, why awareness and treatment are so important, and the impact of intervening for this disease. It is not intended as individualized health advice. If you do have questions during the webinar, remember to click the question and answer button on your screen to submit your questions, and we'll try to get to as many as we can, time permitting. Before we begin, make sure you have your speakers turned up fully so that you can hear the presentation clearly. Without further ado, it is my great pleasure to welcome our speaker today, Dr. Sandra Kim. Sandra is an associate professor and clinician teacher in the Department of Medicine and Division of Endocrinology and Metabolism at the University of Toronto. She is the division head of endocrinology at Women's College Hospital and past director of the osteoporosis program. Her clinical and academic focus is on osteoporosis and metabolic bone disease. Dr. Kim was the past chair of our Scientific Advisory Council and is the current chair of our Guidelines Committee. She led the Pharmacotherapy Working Group for the 2023 Canadian Osteoporosis Clinical Practice Guideline Update and serves on the Canadian panel for the International Society for Clinical Densitometry. Dr. Kim is actively involved in teaching at both the undergrad and postgrad levels and is the recipient of several awards. She is also involved with Ontario Osteoporosis Strategy in providing osteoporosis care to underserviced communities via telemedicine. It's my great pleasure now in welcoming Sandra.
Great. Thank you, Kerry, for the kind introduction. I hope everyone can hear me okay. As Kerry mentioned, I'll be speaking about the importance of fracture risk assessment and treatment in osteoporosis management. So this is my disclosure. I have no relationships in terms of financial sponsors or commercial entities, no potential conflicts of interest for this presentation, and I will not be discussing any off-label use of medications and will be referring to only published national, international guidelines and articles. As Kerry mentioned, I'm a member of the SAC for Osteoporosis Canada Guideline Scientific Advisory Committee, and I'm also been involved with the 2023 Osteoporosis Canada Guideline Update. So by the end of today's session, I'm hoping that all of the participants will appreciate and recognize the burden of osteoporosis and the impact of osteoporotic fractures. and be able to implement an approach to osteoporosis screening and fracture risk assessment based on the updated Osteoporosis Canada guidelines. And finally, be able to apply guideline recommendations for treatment initiation. So as an introduction, I'm sure all of you are aware that osteoporosis is the most common skeletal disorder that compromises bone strength and is really characterized by low bone density, but also poor bone quality. And the most serious consequence of this is fragility fractures. We define fragility fractures as fractures after the age of 40 that occur in the setting of low trauma. And this excludes fractures of the head, neck, face, hands, and feet, also the ankles. And you'll hear,
Sandra, sorry
yeah.
to interrupt, but we can't see your slides.
Oh, Roy, I had it up before. I think something happened. Is it because you unshared? Okay, let me see again.
Sorry to interrupt.
Oh, sorry. Yeah, let me try the share again. I think it's because we had the other slides. Okay. Can you see the slides now?
Now we can. That's great. Thank you.
Okay, wonderful. Thank you. Sorry about that, everyone. So just talking about osteoporosis and related fractures. As I mentioned, the most serious consequences is a fragility fracture with compromised bone strength. And when we talk about major osteoporotic fractures, these include fractures of the spine, hip, humerus, and distal forearm. So how do you make the diagnosis of osteoporosis? So one way is to diagnose based on bone density testing with a T-score of minus 2.5 or less, and this is based on their WHO criteria. We know that a low bone density of 2.5 standard deviations or lower below the peak bone mass is definitely an indicator of increased fracture risk. And this is modified by age, sex, and other factors. And we can make this diagnosis if you have a T-score of minus 2.5 or less in postmenopausal female or males who are older than age 50. However, another way to diagnose osteoporosis is a clinical diagnosis without the bone density, in that you could say that a person who is 50 years and older who've had a low trauma fracture of the hip, spine, humerus, or pelvis after the age of 40, regardless of the bone density. Another way to make a clinical diagnosis of osteoporosis is if the 10-year fracture risk estimation is greater or equal to 20% using either the FRAX tool or the KEROG tool. And I just want to highlight that osteoporosis is known as a silent thief, since bone deterioration can occur over many years with the aging process without any symptoms until the first fracture occurs. So we know that there is a very high burden of osteoporosis in Canada, with over 2 million Canadians living with osteoporosis. We know that osteoporosis is mainly a disease of older females, with the risk increasing with aging. However, it does also affect males, and the lifetime risk of an osteoporotic fractures in Canada is about 44% in females and 25% in males. And we know that more than 80% of all fractures in people who are 50 years and older are caused by osteoporosis. And osteoporotic fractures are associated with morbidity, decreased quality of life, loss of independence, and increased mortality. And this is particularly the case with hip fractures, as well as vertebral fractures. And from the PHAC, the Public Health Agency Canada data, most recently from 2019 to 20, we know that about 1 in 5 Canadians who have a hip fracture will die within 1 year, the following year, of any cause. So there is definitely a link to increased mortality, especially with hip fractures. And with all of this, there is a high economic burden to the healthcare system. So osteoporosis is a huge burden in Canada. This slide is to highlight that the first fracture predicts the second fracture. So similar to how like strokes and heart attacks, the risk of a subsequent event or a subsequent fracture is greatest within a short period of time after the first event. And greater consideration should be given to a fracture that has occurred within the last 2 years. Unfortunately, despite the fact that we do have effective pharmacotherapy agents for treating osteoporosis, as well as having guideline recommendations, there continues to be a large care gap in those who are at high risk for fractures. And this has been repeatedly shown in many studies in Canada as well as other countries. So there are many Canadians who have suffered from a fragility fracture who remain undiagnosed and untreated. And based on available studies, this is about 50 to 80% of females. And the care gap is even greater in males, up to 90% who've had a fracture, yet not assessed for osteoporosis and not given any treatment options. And as a result, there are more males that are likely to not receive any intervention, and males have a greater fracture-related morbidity and mortality and suffer higher rates of subsequent fractures. This problem of the care gap is likely multifactorial, related to lack of awareness. There's many people who underestimate fracture risk. And there has been a lot of things in the media and in the press that has made a lot of people afraid of potential harms that may be associated with osteoporosis medications. So Osteoporosis Canada released its updated clinical practice guidelines in October of 2023. It was published in the CMAJ, and this represents an update to the prior guidelines from 2010. And this updated guidelines is grouped under the sections of exercise, nutrition, fracture risk assessment, treatment initiation, pharmacologic interventions, duration and sequence of therapy, as well as monitoring. So there's 25 recommendations and 10 good practice statements. Today, I will be focusing really on the fracture risk assessment and treatment initiation, as well as monitoring. And I won't have enough time to talk about the exercise and nutrition recommendations. So I really encourage all of you to look at those recommendations on your own, and that there are many tools and apps that are available on the Osteoporosis Canada website, specifically for exercise and nutrition. So the scope of the guideline quickly is really intended for primary care professionals in Canada. And the guidelines apply to community dwelling postmenopausal females, as well as males who are 50 years and older. And the purpose of the guideline is to optimize skeletal health and prevent fractures throughout the older adulthood. And the focus of the intervention is really for primary osteoporosis. So it does not address the complexity of secondary osteoporosis, such as osteoporosis related to chronic kidney disease, cancer, high dose glucocorticoids, or premenopausal osteoporosis. And I just want to highlight that with the development of the updated guidelines, there was significant input and engagement from patient partners, as well as from primary care providers. And not only setting the priority areas, but in every step of the development process. So just a quick word about GRADE, because the guidelines update followed the rigorous framework of the GRADE methodology. That this methodology of developing guidelines is not just about the balance of weighing the benefits versus the harms, but it also considers the importance of patient values and preferences, as well as the resources and equity and acceptability and feasibility that we have in Canada. So it's very important to keep this in mind in the public health system that we have in Canada. in some of the recommendations that are given. And when applying the recommendations in the updated guidelines, it's very important to understand what are the strengths of the recommendations are with the grade framework. So a strong recommendation is given when the benefits clearly outweigh the harms, and this is when clinicians should be applying this recommendation to almost all patients in that setting. And in that case, we would say the wording, "we recommend." Conditional recommendations is when benefits probably outweighs the harms in most settings. And this is where it is a bit more nuanced, and clinicians should recognize that there are maybe some different choices will be appropriate for each individual. And here we say the wording, "we suggest." So we're going to go in first into the screening and fracture risk assessment recommendations. And to highlight the application of recommendations, we'll be using a case throughout the presentation. So this is a case of a 67-year-old female who had a recent distal radius, like a forearm fracture, from a simple fall on the ice. She has no past medical history, otherwise healthy, not on any medication. She's postmenopausal, went through menopause at age 49, and never been on menopausal hormone therapy. No smoking or alcohol history, no family history of osteoporosis, and there is no family history of parental hip fracture. So the question is, what are the important elements in a clinical assessment for this individual? Would you order a baseline bone density? And how would you assess her 10-year fracture risk? So the updated guidelines recommends all postmenopausal females and males who are 50 years and older that first of all, to be engaged in balance and muscle strengthening exercises at least twice a week, and to eat foods that are rich in calcium and protein, and also a minimum vitamin D supplement of 400 units a day. So this is for all postmenopausal female and males who are 50 and older. And as I mentioned before, I won't have time to discuss the details of the exercise and nutrition recommendations. So I again encourage you to review this on your own. And in addition to these non-pharmacological recommendations, the guidelines recommend that postmenopausal females and males over 50 and older be assessed for risk factors, do a clinical assessment for risk factors for osteoporosis, and also signs, being assessed for signs of undiagnosed vertebral fractures. So what does that entail? So the updated guidelines have identified these risk factors being particularly important in the clinical assessment, which include previous fracture after the age of 40, steroid use of glucocorticoids for 3 months or more in the last year, and this is defined as a prednisone dose equivalent of 5 milligrams or greater daily. And this is highlighted because this is one of the risk factors that has been changed from the 2010 guidelines, where previously it was a prednisone dose equivalent of 7.5 milligrams. So this has been changed to 5 milligrams. The other risk factors that is very important is falls. So increased risk of falls is defined as 2 or more falls in the last year. And this is also highlighted because this is a new risk factor that has been included with the updated guideline. Having a parent, a mother or father who had a hip fracture, and having a BMI of 20 or less, and again highlighted because this is a new addition to the updated guideline. And obviously, to know someone's BMI, you would need to know the weight and height. Being a current smoker, alcohol consumption of 3 or more drinks a day on average, and having a secondary cause for osteoporosis. So these are important risk factors to identify in your clinical assessment. Also in the clinical assessment is assessing for possible signs of vertebral fracture that has been not diagnosed before. So this would include a prospective height loss of 2 centimeters or more. So if you've have objective measurements over the years and prospectively to say that there's been a height loss of 2 centimeters or more, or a historic height loss of 6 centimeters. So that's just based on the patient's own account of their prior height. And doing a physical exam to assess the rib to pelvis distance, as well as looking at the occipital to wall distance. So why is it important to do this clinical assessment? Is because 2/3 of all vertebral fractures are actually painless, meaning that they're asymptomatic and silent, and therefore these physical exam findings or the prospective or historic height loss, it may be the only sign of an undiagnosed vertebral fracture. So the rib to pelvis distance of 2 finger breadths or less in the mixed axillary line would be suggestive of a possible lumbar vertebral fracture, whereas the occipital to wall distance of 5 centimeters or greater would suggest significant thoracic kyphosis, which would be suggestive of a possible thoracic vertebral compression fracture. And in any of these instances, this should prompt clinicians to do a screening thoracolumbar X-ray. So in terms of the screening, who should get a bone density testing and a 10-year fracture risk assessment based on the updated guidelines? So all patients, male or female, who are 70 years or older with no risk factors should get a baseline bone density testing, along with doing a 10-year fracture risk assessment. For those who are 65 to 69 years of age, you only need one risk factor based on the prior slides that I showed to get a bone density. And those who are 50 to 64 years of age, if you've had a previous fracture or 2 or more risk factors, then you should these patients should also get a baseline bone density testing. So the updated guidelines are using a similar targeted approach based on age and risk factors, similar to the 2010 guideline. However, there's a more simplified list of risk factors that I showed you, and with the addition of increased falls risk, a lower steroid threshold, as well as including a BMI rather than just a weight. And otherwise, everyone else who are 70 and older should get a baseline bone density. This is a conditional recommendation with low certainty in females and very low certainty in males. And once you have the bone density, which tool should you use for the fracture risk assessment? So in Canada, we have 2 commonly used tools to do the 10-year fracture risk assessment, which is the CAROG tool and the FRAX Canadian tool. In 2010 guideline, they suggested that either tool could be used. And many of you would be probably familiar with the CAROG tool, where only the femoral neck bone density and age is needed to and using the gender specific graph, you would plot it out to find out whether the patient falls into the low risk, moderate, or high risk category, with a caveat that if anyone had an osteoporotic T-score of -2.5 or less, would be at least moderate risk. The FRAX tool similarly looks at the patient's age and gender, as well as the femoral neck bone density, but it has additional inputs, including the BMI, history of parental hip fracture, smoking, alcohol use, and secondary osteoporosis. So there's more variables to put into the FRAX tool. But both tools only use the femoral neck T-score, and studies have shown that between the 2 tools, there is actually very high concordance of 90% of the time falling within the same category. However, when there is a discordance between the 2 tools, FRAX appears to be superior to CAROG. And we have to remember that there are limitations to both tools in that it may actually underestimate fracture risk when there is a very, very low bone density score at the spine or total hip, since it only looks at the femoral neck bone density. And the other limitation is that both tools don't assess the recency of fracture, and nor does it account for multiple fractures necessarily, or history of recurrent falls or other comorbidities. So with the updated guidelines in 2023, the main change is that the FRAX is the preferred tool rather than using Kerrog. So back to our case. So as you recall, we have a 67-year-old female who had a recent forearm fracture. She has no other risk factors. And because she's between age 65 to 69, with one risk factor being her recent fracture, she is eligible for a bone density test. And she has, this is her scores, as you can see. She has osteoporotic T-score at the lumbar spine of -2.7, and the femoral neck and total hip scores are in the osteopenic range. And when we plug all the variables into the FRAX calculator, her 10-year fracture risk for major osteoporotic fractures comes out at 13%. So the question is, should this patient be offered pharmacotherapy? So we'll go into now treatment initiations and pharmacotherapy interventions. So who should be started on osteoporosis pharmacotherapy and who benefits the most? We know that based on randomized controlled trials that higher risk patients benefit the most. So those include patients that have already fractured. So these are patients who already declared themselves having osteoporosis from breaking their bones. And especially based on the randomized controlled trials, the benefit seems to be especially the greatest for people with vertebral or hip fracture. And as I alluded to before, the recency of fracture is also very important based on many observational studies showing that the risk of the subsequent fracture is the greatest within the first 1 to 2 years. And therefore, patients who had a very recent fracture, they're at an imminent risk for a subsequent fracture. So this should be also taken into account. Clinical trials data support benefit when patients have a bone density diagnosis of osteoporosis with a T-score of -2.5 or worse, as well as shows great benefit when the patient has had a prior fracture, especially vertebral fracture. However, what is not as well assessed in clinical trials is those who have osteopenia, so a T-score between -1 to -2.5, with a FRAX score of 20% or greater. So with the updated guidelines, you can see that that there has been some changes in that we have changed the threshold for pharmacotherapy. So, and also there is, now we are taking an approach of a hybrid approach, not only looking at the 10-year fracture risk calculation, but also looking at the bone density score along with age. So similar to the 2010 guidelines, if a patient has a 10-year fracture risk of 20% or greater, or if the T-score is -2.5 and the patient is 70 years or greater, then there is a strong recommendation for osteoporosis pharmacotherapy as they are going to derive the greatest benefit. And similar to the 2010 guidelines, if the patient had a prior hip or spine fracture or multiple fracture, they automatically are considered very high risk for fracture to have a strong recommendation for treatment. With the updated guidelines, there has been a shift in terms of the threshold for our kind of the intermediate, what used to be called the moderate risk category. So patients who have an estimated 10-year fracture risk that is 15% to just under 20%, or if they have osteoporosis on their bone density T-score, but under the age of 70, then is a suggest pharmacotherapy where the benefits of a treatment is in the intermediate range. And finally, those who do not have osteoporosis on their bone density and where their 10-year fracture risk is under 15%, osteoporosis pharmacotherapy is not recommended. So with the updated guidelines, what is the key thing to remember is now we are recommending a hybrid approach to treatment threshold, and not only using a 10-year fracture risk calculated threshold, but also you can use the bone density with age threshold, and those that had a hip, spine, or multiple fractures automatically would be considered high risk for recommended pharmacotherapy. So why are we recommending a hybrid approach with the updated guidelines? As I alluded to before, there are limitations to the 10-year fracture risk assessment tool, whether you're using CAROG or FRAX, because both tools only use the femoral neck bone density. And we see a lot of patients who may have not such a bad bone density at the femoral neck, but they have significant osteoporosis or very low bone density at the other side, so the lumbar spine or total hip. And as a result, those patients may have an underestimation of their 10-year fracture risk. It also doesn't account for multiple fractures, and it doesn't put a higher, rating. And if the patient had a hip or spine fracture, and these tools don't account for the recency of fractures, nor do they account for risk for falls. And we have to remember these tools have been developed based on observational data and has not been as well assessed in clinical trials. And similarly, just using a bone density threshold has limitations as well, since a bone density threshold does not account for clinical risk factors, which are very important. And therefore, you may have underestimation of risk in those who may have not such a bad bone density, so non-osteoporotic BMD, but have many risk factors. So this slide is just to, again, highlight that with the updated guideline, that this intermediate risk category, we have really narrowed it down to say that, that if you have a 10-year fracture risk between 15 to 19%, or if you have osteoporosis and under age 70, is a suggest pharmacotherapy. This is a change from the 2010 guidelines, where the moderate risk category was the 10-year fracture risk was a wider range between 10 to 20%, and it said consider pharmacotherapy. And so this is an update into help clinicians and patients to better understand that the people who are in the intermediate risk category, this more narrowed criteria, that the benefits of treatment probably outweighs the harms for these intermediate group. And as I highlighted before, we have to remember that fracture risk is a gradient. And keeping in mind that a patient who had a recent fracture, just like our patient that that we're using as a case study for this presentation, that patient had a recent fracture. So we have to keep that in mind, especially for those who fall in the intermediate risk suggest pharmacotherapy group. So back to our case, our patient has osteoporosis on her baseline bone density at the spine, but the femoral neck T-score is minus 1.3. And as a result, her 10-year fracture risk, even accounting for her recent fracture, the FRAX score only comes out as a 13%. However, with the updated guidelines, she actually falls in this suggest pharmacotherapy category because of the fact that she does have osteoporosis and she is under age 70, even though her 10-year fracture risk is only 13%, so even below that 15% threshold. So with this patient, since she falls in the suggest, you would offer her osteoporosis pharmacotherapy, and you would probably be stronger with your recommendation, given the fact that she had a recent fracture. And the question is, which pharmacotherapy agent would you recommend if she is agreeable, and would you order a vertebral imaging? So in terms of the vertebral imaging, we talked earlier about the importance of doing a clinical assessment for undiagnosed vertebral fracture. And I mentioned that her physical exam was unremarkable. So she did not have any height loss, and she didn't have any physical exam findings suggestive of an undiagnosed vertebral fracture to warrant a spine X-ray. However, the updated guidelines do recommend that vertebral imaging be considered for those who are 65 years and older, who do have osteoporosis on their bone density, or if the 10-year fracture risk is between 15 to 19.9%. And this really highlights the importance of identifying undiagnosed vertebral fractures, especially those that fall into that intermediate risk category, because finding that undiagnosed vertebral fracture may actually push that patient to the high-risk category. In fact, they may go from the intermediate risk category, then move up to the strong high-risk recommend pharmacotherapy group, and that might change management strategies and duration of treatment. So that's why this recommendation is in place. So prior to initiating pharmacotherapy, the guidelines give the best practice statement that all patients before starting treatment should be assessed for possible secondary causes of osteoporosis and potential limitations when considering specific medications by ordering some baseline biochemistry, as you see here in this table, which is similar to the 2010 guideline. So this would include calcium phosphate, checking renal function with a creatinine, alkaline phosphatase, TSH, doing a serum protein electrophoresis only for patients who have vertebral fractures and ruling out multiple myeloma, and doing a vitamin D assessment if there are risk factors for insufficiency or if starting on a very potent anti-resorptive agent. The guidelines does have a supplement, a table that's available that you could see where it lists what are the risk factors for vitamin D insufficiency, which I'm not showing today. Unlike many other chronic conditions, such as hypertension and diabetes, osteoporosis pharmacotherapy has its unique challenges. This includes the fact that there has been some rare risks associated with long-term potent anti-resorptive therapy, which include atypical femoral fractures, which are unusual fractures of the thigh bone, as well as the rare risk of osteonecrosis of the jaw, which is defined as exposed bone of the jaw, whether it's the mandible or the maxilla, after osteoporosis pharmacotherapy exposure for more than, with the exposed bone, more than 6 to 8 weeks. The other challenges that we face with osteoporosis medications is that there has been well-documented risk of rapid bone loss and risk of rebound vertebral compression fractures in those who are on denosumab with delayed dosing or if stopping denosumab. And finally, the challenges that we also face is the cost and feasibility of anabolic agents such as teriparatide and romosozumab. Due to the high cost and the feasibility of the injection schedule, this is a big barrier in terms of many patients not being able to access anabolic therapy. So these are the agents that we currently have available in Canada. And they can be classified as anti-resorptive, which inhibit osteoclast activity, or anabolic, are the ones that actually stimulate new bone formation. So bisphosphonates include alendronate, risedronate, which are the oral agents, and we have one intravenous agent approved for osteoporosis treatment in Canada, which is zoledronic acid. The key features of bisphosphonates is that they have long skeletal retention in the bones once you've been exposed to the medication for a period of time. And the efficacy of the medication seems to plateau after 3 to 6 years. And the longer a person is on the medication, there has been this increased risk of those rare complications that I mentioned, atypical femur fracture and osteonecrosis of the jaw. And therefore, the longer the patient is on bisphosphonate therapy, there tends to be kind of a waning in terms of the benefit to risk ratio. Denosumab is a rank ligand inhibitor, so it's a monoclonal antibody against rank ligand, which stimulates osteoclasts to become active. Unfortunately, though, although denosumab is very effective, it has no skeletal retention, and therefore, when it's stopped or there's a delay in the dosing, there is rapid bone loss and the risk of rebound vertebral fracture, as I mentioned. And similar to bisphosphonates, there is an associated risk of atypical femoral fracture and osteonecrosis of the jaw that's stable over time. But the benefits to a risk ratio is still favorable even at 10 years duration of therapy. Raloxifene and estrogen hormone therapy is only available for postmenopausal females. And in terms of the anabolic agents, teriparatide is a parathyroid hormone analog, and it's a 24-month duration of treatment that's by subcutaneous injection. And this medication has not been associated with the risk of atypical femur fracture or osteonecrosis of the jaw. Romosozumab is the newest agent that we have available. It's a 12-month duration of treatment. It has a dual anabolic and anti-resorptive effect. It's an anti-sclerostin inhibitor, and it has been associated with the rare risk of atypical femur fracture and ONJ. And as I mentioned, the main barrier to anabolic therapy is that it's very expensive and very cost prohibitive because there's not a lot of support in terms from government, and only patients who may have a private drug plan are able to afford it. But the anabolic therapy has shown benefits in terms of rapid bone density improvement and significant rapid reduction in fractures. So in terms of initial treatment of choice, the updated guidelines recommend that bisphosphonates are first-line therapy for most patients. This is a strong recommendation with high certainty evidence in females and moderate certainty evidence in males. And there's a remark there that oral bisphosphonates may be preferred over the IV zoledronic acid because of drug coverage and cost, and access to an infusion centers may be barriers for the zoledronic acid. We do have a recommendation that menopausal hormone therapy may be an alternative to bisphosphonates for females who are 60 years or within, or they're younger than 60 years or within 10 years of their postmenopause. If the individual prioritize the alleviation of substantial menopausal symptoms, then obviously there has to be a discussion in weighing the risks and benefits of menopausal hormone therapy. Denosumab is recommended as an alternative option to bisphosphonates. So this is when there are contraindications or substantial intolerance or barriers to bisphosphonates. And it's very important to communicate the need for long-term treatment in patients who are starting on denosumab because of the risk of rapid bone loss and risk of rebound vertebral fractures with delayed dosing or stopping, and the importance of the need to transition to an alternative anti-resorptive agent if denosumab has to be discontinued for whatever reason. And finally, in terms of anabolic therapy, anabolic upfront therapy is recommended in only selective patients. So this would include patients who've had recent severe vertebral fractures or more than one vertebral fracture with osteoporosis. And really, the choice of anabolic therapy will depend on the affordability and feasibility of the injection schedule. So when we think about treatment duration, it's very important to consider what are the long-term safety and efficacy data. So for bisphosphonate therapy, we know, as I mentioned before, that the longer the treatment duration on bisphosphonates, there is an increased risk of atypical femur fracture and an increased risk of ONJ. That is dependent on the duration of therapy. And because the anti-fracture efficacy tends to plateau between 3 to 6 years, the benefit to risk ratio will wane over time with prolonged duration of bisphosphonates. And as a result, the concept of bisphosphonate drug holiday has come into play to minimize the prolonged exposure in reducing, albeit very rare, risk of AFF and ONJ. And this concept of drug holiday is only unique to bisphosphonates. In terms of the duration of therapy of denosumab, looking at long-term safety and efficacy data, as I alluded to, the risk of AFF and ONJ is also there with denosumab. However, the risk of these rare risks tend to be stable and not increase over a long period of time. So it's stable over 10 years. And this data comes from the Freedom Extension trial. This Freedom Extension trial also showed that even at 10 years, the bone density benefit and the anti-fracture efficacy seems to still continue even at 10 years. Therefore, the benefit to risk ratio is still favorable at 10 years. However, we are not certain what the safety and efficacy is beyond 10 years. Unfortunately, at this point, we don't have any large studies beyond 10 years of therapy. And given that denosumab does not have any skeletal retention, there's no drug holiday with this medication, and you would need to transition the patient to another agent if stopping the medication, which only gives partial protection from the rapid bone loss. So the recommendation for bisphosphonates that if you start on bisphosphonate, the initial treatment duration should be 3 to 6 years. And we could operationalize this, based on the patient's kind of category. So someone who fits in the suggest category and the intermediate benefit, you may consider, more like 3 years of treatment, and as opposed to people who are in the strongly recommend category, where it would be definitely need to treat at least 6 years. After the initial 3 to 6 years duration of therapy, this is when we would recommend stopping the medication for a bisphosphonate drug holiday and reassessing 3 years later about resuming for osteoporosis pharmacotherapy. However, just to highlight here that we do have a remark that an earlier reassessment should be done earlier than 3 years in those who are at much higher risk for fracture. So those would include those patients with hip fracture, a very, very high FRAX score, people with secondary osteoporosis, and people who may have a new fracture or new risk factors. During the initial 3 to 6 years of therapy, if there are concerns of inadequate response or substantial concerns of ongoing fractures, then we have a good practice statement that you would not stop the medication for a bisphosphonate drug holiday, but rather you would extend treatment or think about switching pharmacotherapy. And this is when you may seek consultation from an osteoporosis specialist. And in regards to denosumab, because of the fact of the risk of rapid bone loss with delayed dosing and stopping the medication, we recommend that long-term therapy be exercised in those on denosumab, and the dose should not be delayed by more than 1 month. If a patient had to come off denosumab, we do have some recommendations on how to transition off denosumab. So we know that patients who've been on denosumab for a shorter duration of time, so people who've been on it for 2 years or less, so less than four or less doses, you can transition the patient to bisphosphonates 6 months after the last dose, and the bisphosphonate transition should be for at least 1 year. However, those who have been on denosumab for more than 2.5 years, so 5 or more doses, these patients are at higher risk of rapid bone loss with the transition, and should seek advice from an osteoporosis specialist on how best to transition off denosumab in those cases. So back to our case. So this patient, as I mentioned, fell into the suggest category for osteoporosis pharmacotherapy, And we also, even though she had no signs of undiagnosed vertebral fractures, we did a base screening vertebral spine X-ray, and there was no occult fractures. She agreed to start on osteoporosis pharmacotherapy, and following the guidelines, she was started on oral bisphosphonates. And we explained to her that she would be on treatment for at least 3 to 6 year duration, and that we would, think about maybe 3 years duration of therapy, depending on how things go. So how long would you treat for, and when would you repeat her bone density? So in terms of monitoring, we recommend that during the treatment duration that the patient should be assessed on a regular basis in terms of their adherence and tolerance to the medication, and for any new fractures or any new risk factors. And it's very important to counsel the patient on the rare risk of atypical femur fracture and ONJ. When to repeat bone density, we recommend that once you've initiated pharmacotherapy, that the bone density be tested in 3 years. And there is a remark at the bottom, as you can see, that a shorter interval can be considered, shorter than 3 years, if the patient has active secondary causes of osteoporosis, if they end up having a new fracture during their duration of treatment, or new risk factors such as now going on high-dose steroids. If the patient is not a candidate for or chooses not to take pharmacotherapy, then we recommend bone density testing in 5 to 10 years in those who have a 10-year fracture risk of less than 10%. We would recommend a bone density retesting in 5 years if the 10-year fracture risk is between 10 to 15%, and 3 years if the 10-year fracture risk is 15% or greater. So just to summarize, what are the key takeaways? The key takeaways is that in Canada, there is a high burden of osteoporotic fractures, and I highlighted that there is a large care gap in Canada, and primary care providers have a very important role in helping to reduce this care gap, because often these patients are first present in the primary care setting, and this is the best time and opportunity to do the assessment, the clinical assessment for risk factors, and to do the screening for osteoporosis, and increasing the awareness of the increased morbidity and mortality associated with osteoporotic fractures. And intervening earlier can really make an impact in reducing the care gap that we have in Canada. So the screening approach, as I mentioned, is a targeted approach based on age and risk factors. Baseline bone density in all people who are 70 years or older if there's no risk factors. But if you're younger than 70, then you should have a bone density at age 65 if you have at least one risk factor. And if you've had a prior fracture or 2 or more risk factors, and between the age of 50 to 64, you should get screening earlier. And I highlighted the importance of assessing a clinical assessment for undiagnosed vertebral fractures. The updated guidelines also highlight that the 10-year fracture risk assessment be done with the bone density, and that FRAX is the preferred tool over CAROG. It's very important that we take into account that the recent fracture within 2 years, that we put a greater importance on this, because that is a predictor of a fracture, an imminent fracture, rather than a fracture that occurred remotely. The important thing of the updated guideline is that now we are recommending a hybrid approach in identifying those that would be appropriate for treatment, using either the FRAX threshold or a T-score with age threshold. And those who've had a hip, spine, or multiple fractures are automatically should be considered high risk and a strong recommendation for osteoporosis pharmacotherapy. Bisphosphonates are recommended as first-line therapy for most people initiating osteoporosis treatment, with the initial treatment duration of 3 to 6 years before considering a drug holiday. And I think with this new recommendation, with this define treatment duration, I think most patients would probably be more likely to agreeable to pharmacotherapy, and it will increase the likelihood of adherence if they know that it's for a certain finite of time before considering a drug holiday. And this will also reduce the overtreatment and reduce the rare risks that are associated with prolonged bisphosphonates. Denosumab should be considered if there are contraindications, intolerance, or barriers to bisphosphonates, and patients have to understand that this is a long-term commitment and it should be uninterrupted therapy. And if there's any need to stop, the patient needs to be transitioned to another antiresorptive agent. And anabolic therapy should be considered for selected patients who are at the highest risk for fractures. And monitoring is very important once started on treatment, and that a reassessment be done with a bone density in 3 years. So I just want to highlight that the Osteoporosis Canada website has many resources and tools available, including an executive summary and quick reference guide. There are, with this link, you'll see that you can access the appendices, the supplemental information, and there are KT tools and apps. I didn't have a chance to go over the details of the nutrition and the exercise recommendations, but you can see that we do have a lot of tools there, as well as some video clips and apps in terms of calculating calcium intake, for example. So I'll stop there and open it up for questions. I know we're kind of short on time, but I also want to highlight that Osteoporosis Canada is hosting the Canadian Musculoskeletal Conference this March 27th, and that there are still some spots available if you're interested in attending this conference. It's a hybrid event, both in person, and there is a virtual option as well. So I will end there and pass it over to Kerry.
Wow, that's great, Sandra. Thank you. We do have time for a couple of questions. So let's just start with this one. Somebody's asking, after a 3-year holiday from bisphosphonates, can you restart them again if you fall within the mid-range?
Absolutely. So if a patient falls in the suggest category, in the intermediate category, just like the example patient that I presented today, let's say after 3 years of therapy, and the patient has done well, was adherent to the 3 years of oral bisphosphonate therapy, there's been no new risk factors such as a new fracture or needing steroids, and the repeat bone density at 3 years is at least stable or improved. I would stop it for a bisphosphonate drug holiday, and absolutely, that patient is still at risk. So you would reassess in 3 years, and you would reassess earlier if there are any additional risk factors to restart bisphosphonate therapy. So really, the new guidelines are recommending intermittent bisphosphonate therapy, kind of like long-term for those who are still at risk.
Okay, we'll just have one more question. How accurate is the forearm image to detect osteoporosis?
That's a very good question. So the forearm bone density, we will do the forearm bone density if one of the other conventional sites, so the lumbar spine and the femoral neck and total hip sites, are not valid for whatever reason, such as like they had a fracture in the area, or they have hardware from prior surgery. So that's when we use the forearm. So the forearm is not a conventional site. There's not as much data. So obviously you could still make the diagnosis of osteoporosis based on the T-score at the forearm, and we use the proximal 1/3 forearm, the proximal 1/3 of the radius where we do the bone density measurement. So it can make the diagnosis of osteoporosis. However, with the updated guidelines, we just don't have enough data to predict the forearm, predict the chances of having fractures with just the forearm bone density. As a result, when we use that T-score threshold, the other threshold with age, that is only using the T-score at the lumbar spine, femoral neck, and total hip, and not the forearm. But we will sometimes have to use the forearm because of the fact that the other sites are not valid. I hope that answers your question.
Wow, that's great, Sandra. I'm going to wrap things up here. I just wanted to point out to folks that there's lots of information on nutrition and exercise on our website. I know that there were questions that we didn't get a chance to get to, but if you go to osteoporosis.ca, you will see a lot of information there. So at this point, I do want to thank Sandra again for such an informative presentation on fracture risk assessment. I think we all enjoyed that. And I also want to thank APOTEX for providing an unrestricted educational grant today as well. And for more information on osteoporosis, as I said, please visit our website at osteoporosis.ca. Our website includes many tools, including our new nutrient calculator, podcasts, quizzes, and a repository of our past webinars. This webinar will be available probably, I think, within 24 hours for replay. And finally, I want to thank all of you for joining us today. I hope you join us again soon and wishing you a great rest of your day. Thanks, everyone.